Thanks, Dr. Chow. So my name is Ciara. I'm one of the first-year cardiology residents, and today I'm going to be talking about the mitral valve, talk called Back to Basics and Biggest Hits. I have no disclosures. In terms of objectives, I'm going to discuss the etiologies of mitral stenosis, as well as describe some echocardiographic features of mitral stenosis and how we can grade the severity of MS by echo. Also be discussing some etiologies of MR, and then similarly how we can use echo to grade the severity of mitral regurgitation. There will be some cases that are kind of worked into things, some biggest hits from the Black Book. Which if we could have some audience participation from, that would be greatly appreciated. And just to start off, so this is on my first slide, but a schematic of the mitral valve, which is a pretty complicated valve. There's a lot of different parts to it, from the leaflets, the commissures, and the chordae, the pap muscles, and there's a lot of things that can go wrong with such a complicated valve. All right, so starting off, we'll have a little case to start, and the one-liner is that there's a 52-year-old woman who is presenting with dyspnea. And there's just a couple clips here. So this is the first one, parasternal short. But maybe if we could have someone from the audience kind of speak to what we see here, and I can keep it. Oh, sorry, it's not looping. There we go. Maybe one of the C1s or C2s.
Hey, Ciara, it's Samir. Can you hear me?
Yeah.
Sure, so I can go. Sorry, it's a little bit choppy, but no pericardial effusion. Harvey looks probably a bit enlarged, and it looks like there's some septal bowing. The mitral valve itself, in keeping with the theme of this talk, looks very thickened and doesn't seem to open very well. So probably some degree of mitral stenosis. Looks pretty severe just visually though. And hard to comment on LV function on this view, but so far looks okay. Perfect.
And then here's just a second view from the apical 4.
Sure, so 4-chamber view. Still no pericardial effusion. Looks like there's biatrial dilatation. Again, the LV function looks pretty good, still with that septal bowing in diastole. And then the valve itself, mitral valve itself, still looks very thickened and calcified. Looks like there's turbulent flow going through. Not a lot of mitral regurgitation.
Perfect, thanks, Samir. So just briefly, in terms of etiologies of mitral stenosis, so as we all know, rheumatic mitral stenosis is the most common, which is really characterized by fusion of the commissures, which we just saw on the previous 2 slides. In terms of other etiologies, degenerative or calcific mitral stenosis, with mitral annular calcification being the main lesion is another less common, but etiology of mitral stenosis. Rarely you could see things such as congenital MS, and then just kind of thinking more broadly in terms of other causes of LV inflow obstruction. You could have a atrial myxoma, a very large thrombus, I suppose very severe diastolic dysfunction. So just I'll briefly just touch on rheumatic mitral stenosis. So as I said before, it's characterized by fusions of the commissure and diastolic doming, which you can see the diastolic doming in this still here from the parasternal long. As it progresses, you can get shortening of the chordae and then fusion. The mitral valve leaflets can become quite thickened, which we saw in the previous image. As patients will have had this for longer periods of time, then eventually they can develop calcifications, and then restricted opening is a common feature, which leads to the stenosis, of course. And then we can see on this view of the parasternal short, the typical kind of fish mouth appearance and the fusion of the commissures here. Okay, So before we move into the grading severity of mitral stenosis, we just have another clip to look at. So this is an 82-year-old man with a history of hypertension, CKDs, coming in with, again, also dyspnea. Anyone who wants to take a stab at this one? Maybe one of the cardiology residents again. Any C1, C2s, or C3s on?
Amir, can you help?
I can start calling on people.
Hey, Ciara, it's Hatem.
Thanks, Hatem. Let me make this just a loop again for you.
Yeah. So again, this is a short axis. I think this is at the mitral valve level. So I can't really see the valve leaflets very well, but there is a lot of echo density in the posterior side of the valve. So I can't really comment.
What about this over here?
Yeah, so here this is the apical view for chamber. So again, suboptimal view, but I wonder if there is some prothesis or something in the mitral valve level.
Yeah, so here, and I can appreciate it's kind of hard to see, especially when the images are coming in and out, but we're supposed to see a lot of calcifications on posterior aspect of the mitral annulus to represent degenerative or calcific mitral stenosis. So most commonly, you'd see this affecting the posterior leaflet, and this schematic here, if you look at B, that kind of demonstrates the hemielliptical pattern of calcification in the posterior leaflet. And as this gets worsened, then the rigid annulus can lead to, of course, mitral regurgitation. But then what we can also see is that occasionally the calcifications go to the base of the leaflets, which restrict their opening and can cause functional mitral stenosis. How this can be differentiated on echo from rheumatic mitral stenosis is that, unlike in rheumatic MS, the leaflet tips are typically much thinner, and you should not see the fusion of the commissures on the peristernal short as you would with rheumatic mitral stenosis. Okay, so moving on, we're going to talk a little bit about how we can use echo to evaluate the severity of mitral stenosis. So we'll be talking about the pressure gradient and then different ways that you can calculate the mitral valve area by either 2D colorimetry pressure half-time method using the continuity equation, or PISA as well too. So the mean gradient, we'll start off with that, which is calculated by averaging the instantaneous gradients over the ejection period. So we use color Doppler, apical window, and you can see the tracings here that are traced out. It's derived from transmitral velocity, the transmitral velocity flow curve using simplified Bernoulli equation. You have to report it with the heart rate because it is dependent on the heart rate. Advantages of using the pressure gradient are that it's easy to calculate. You should be able to calculate it on pretty much any patient that you're assessing for mitral stenosis. The disadvantages are that it is dependent on heart rate and flow condition. Next, we'll talk a little bit about 2D telemetry, which is a direct measurement of the anatomic mitral valve area. You obtain this by using still view in the peristernal short axis and trace the orifice and the open commissures in mid-diastole. Patients with AFib, and this is kind of a theme, is that for all of these methods, you need to take several methods, sorry. And you can see down here the tracings that are done in different patients who've had mitral stenosis from the ASC guidelines. Advantages of this method of assessing for mitral stenosis are that it doesn't have any assumptions on flow conditions, compliance, or associated valve lesions. It does correlate with valve area on explanted valves, but there are some disadvantages as well too. And so the disadvantages are that it does require technical expertise, and it would be less reliable in patients with degenerative or calcific mitral stenosis. So in the patient with the second image is maybe less useful than a patient who has more kind of classic rheumatic mitral stenosis. Okay, so next I'll be talking about the pressure half-time method, which can be used to calculate the mitral valve area again. So this is based on the principle that the rate of decrease in transmitral flow is inversely proportional to the mitral valve area. So smaller orifice is going to have a slower rate of pressure decline. So what you do is you take continuous wave Doppler in the apical window, and then you can trace the deceleration of the E wave. And then using that, you can get the pressure half time and then put that into a formula, which will give you the mitral valve area. So 220 divided by the pressure half time. And pressure half time would be the time from the maximal gradient of the across the mitral valve to when the gradient is 50% of the maximal value. In some cases, you don't always have the pressure half time, but you should always be able to calculate the diastolic time. And so you can estimate the pressure half time using the diastolic time and get the product of the diastolic time by 0.29. In patients who do have a bimodal deceleration slope, you want to use the mid-diastolic slope instead of starting at the early slope. And again, in AFib, you want to average over different cycles and avoid the slope from short diastomies. The limitations of using the pressure half time are that the left ventricular diastolic time, which is what you use to measure this, is not just impacted by the mitral valve area, but also compliance of the left atrium, LV dysfunction, and also aortic insufficiency. Advantages are kind of similar to the last one, it's relatively easy to obtain. And then one important thing to remember is that you can't use the pressure half time in patients who have very recently had a commissurotomy. So next we'll talk about assessing the mitral valve area using the continuity equation. So this is based on the theory of conservation of mass, whereby the flow through the mitral valve should equal aortic stroke volume. You can also estimate stroke volume through the PA, but my understanding is that this is not commonly done. And so we have the equation over here on the right, and you input the diameter or the LVOT as well as the velocity time intervals for the aortic and mitral valve. Advantages of using the continuity equation would be that it's independent of flow conditions, but disadvantages would be that there's a number of measurements that are required here. First to calculate the LVOT, but then also to calculate the VTIs both at the aortic and mitral valves. And with all of these measurements, that increases the impact of measurement error and could give you a potentially incorrect output. Also, it can't be used in patients with AFib or who have significant aortic or mitral regurgitation if the assumptions don't hold up. So next we'll talk about the last method of measuring the mitral valve area, which is by PISA method, which is based on using what you look for the area of proximal flow convergence and the hemispherical shape where you have converging diastolic mitral flow on the atrial side of the mitral valve using color Doppler. It gives a measurement of mitral flow, and you can also estimate the mitral valve area by dividing the mitral flow with the maximum diastolic flow, which is determined using continuous wave Doppler. And the equation is right here, and with the inputs that I said before, as well as the radius of the convergence hemisphere, and then the opening angle of the mitral valve leaflets. So an advantage of using PISA is that it can be used in patients with significant mitral regurgitation to assess MS severity, but it is technically demanding, and with so many measurements, then that increases your risk of error and the impact of error in your calculations. So with every condition, we always want to keep in mind to the company that it keeps or associated lesions. So we can also use echocardiogram to assess for consequences of mitral stenosis, such as left atrial enlargement, which we can see over here on the right. There's a quite large left atrium. Of course, you want to assess for associated MR, which is going to impact which method you're going to be able to use to assess the severity of mitral stenosis. And then again, other consequences would be pulmonary hypertension, and you want to assess the PA pressures and tricuspid regurgitation. Another company that mitral stenosis keeps, of course, is atrial fibrillation, which hopefully you should not be using echo to assess that, but potentially that could be the first time that would come to light. So kind of putting things together in terms of staging or grading mitral stenosis. Over here on the left, we have recommendations from the American Society of Echocardiography in terms of classification for mitral stenosis severity. So using the valve area, a valve area of 1.5 centimeters squared would be considered to be mild mitral stenosis, whereas less than 1 would be severe. And then using the mean gradient, if the mean gradient's less than 5, again, that would be considered mild. Whereas if it's greater than 10, that would be considered severe. And then I also included the staging of mitral stenosis from the 2020 AHA valve guidelines, which overall are fairly similar to the grading that's from the ASE guidelines, with some kind of subtle differences. It instead divides into progressive versus just mild and moderate mitral stenosis, and then also interestingly includes actually what the diastolic pressure half time is as a marker here as well too. And then one kind of last thing to mention would be the Wilkins score. So the Wilkins echo score can predict procedural success for patients who are being considered for mitral valvuloplasty based on valve structure. There's 4 areas that it assesses: so the mobility of the valve, thickening of the leaflets, calcification, as well as subvalvular thickening. And each different component of the score would be graded on a score of 1 to 4, with your output ranging between 4 and 16. A score of 8 or less would predict a more favorable outcome in terms of short and long-term outcomes, including survival, which may help guide patients who would be appropriate for valvuloplasty or for. But important things to also consider are whether other factors that aren't really captured by the score. So age, if patients also have concomitant mitral regurgitation, their functional status, and just kind of overall clinical picture. So just to summarize, in terms of evaluating mitral stenosis, the things that you want to be considering are the valve anatomy and morphology, which will give you clues in terms of the etiology of the mitral stenosis, and then grading the severity of mitral stenosis using different methods. Most commonly would be using the pressure gradient, mitral valve area via 2D numeracy or pressure half-time. And then you could also consider using the continuity equation or PISA method in the right clinical context. We'll need to assess for coexisting mitral regurgitation and then assess for consequences or complications such as left atrial enlargement, assess the Ciara severity and estimate PA pressures, and then Wilkins score if you're considering intervention. Okay, so moving on, we're going to switch gears here. We have another few clips to take a look at. And so this is a 65-year-old man who is presenting with worsening dyspnea. I'm going to try and get these to a little. So if there's anyone in the audience that wants to tell us about what they can see on the screen here.
Hey, Ciara, it's Mike. I can go.
Thanks, Mike.
No worries. So just starting with the shot on the left, parasternal long axis shot, there's no significant pericardial effusion I can see. I think the main abnormality that I appreciate is the mitral valve. Looks to be prolapse, particularly the anterior mitral valve leaflet. And then on the color Doppler to the right, we appreciate an eccentric, posteriorly directed jet of MR.
Perfect. I think I have a couple more for you here.
Perfect. So on the short axis shot as well, we can appreciate the mitral valve leaflets are opening well. There's a good bounce to them. I don't really appreciate prolapse in this view, but obviously it's not the geometry that we would see it best in.
Mm-hmm. And then here is our last one.
Yeah, so here as well, that anterior leaflet is very mobile. I don't really appreciate. I don't think it meets the definition of prolapse here, but my images are a little bit choppy on the UHN internet. Otherwise, yeah, there's the LV function looks normal, RV looks normal size, good function. The left atrium looks dilated. The right looks mostly normal.
Perfect. Thanks, Mike. Okay, so we're just going to kind of briefly touch on different etiologies of mitral regurgitation, which we can classify into primary MR, which is really an intrinsic abnormality of the mitral valve leaflets. And within there, then there's still a spectrum that we can think about. So myxomatous changes in mitral valve prolapse, degenerative changes such as calcification, infectious, so patients with infective endocarditis and consequences of that, inflammatory causes, or less commonly than congenital. And then also we can think about, on the other side of things, secondary mitral regurgitation or functional mitral regurgitation, which there's not any intrinsic abnormalities of the mitral valve leaflet, but instead we have a distortion of the mitral valve apparatus due to either remodeling of the left ventricle and or the left atrium. And that would be commonly seen in our patients with cardiomyopathies of, for example, like ischemic cardiomyopathy or non-ischemic dilated cardiomyopathy. Another way that we can kind of classify things is thinking about the type of dysfunction. So type 1 with normal leaflet motion, so you can see that in your patients with ischemic or dilated cardiomyopathy. Type 2, where patients would have increased leaflet motion, so your leaflet prolapse. You see often myxomatous changes. So as in those images that we saw just before. And then type 3A with restricted leaflet motion, causing restricted opening, so patients with rheumatic disease, for example. And then type 3B with restricted leaflet motion, with restricted closure, which it's as in type 1, can be seen in patients with ischemic or dilated cardiomyopathies. Okay, and so here we have another clip. This is a 45-year-old woman who is was admitted to the ward with dyspnea in July. Is there anyone that wants to comment on what they see here?
I don't mind doing it.
Thanks, Taylor.
Oh, it just froze on me though. Is it still playing?
Yeah, sorry, it's supposed to loop, but it likes to pause.
No worries. So we have a 4-chamber here. Just grossly, it looks to be enlarged left atrium and probably some enlargement in the right atrium as well. Normal biventricular function from what I can see here. Looking at the mitral valve, just wondering at the posterior leaflet, I think there might be, I think it actually might be flail, because I see the tip of it just pointing into the left atrium there probably, versus just prolapse.
That's perfect.
Yeah,
And here's
and
the
then
color.
severe MR there as well, more anteriorly directed.
Exactly, that's perfect. Thanks, Taylor. Okay, so now we've seen a couple of patients with mitral valve prolapse in their images. And so mitral valve prolapse has a real spectrum of disease, which is highly variable. The disease is characterized by thickened, redundant leaflets and chordae. And to have prolapse, you need to have systolic displacement of the mitral valve leaflet into the left atrium by 2 or more millimeters from the plane of the mitral annulus, and that should be evaluated on the peristernal long. And as I was saying, the spectrum of disease is really highly variable. You can have patients with very mild disease, just mild prolapse, but without any significant valve compromise. As things progress and you get chordal enlargement, you can get development of mitral regurgitation, and then chordal rupture can cause a flail leaflet, which is what we saw in the last images just now. Okay, and then we have one more before we get into talking about grading of severity of mitral regurgitation. So this is a 40-year-old man who's got a history of non-ischemic cardiomyopathy who is admitted with worsening dyspnea. Anyone want to take this one?
It's
I can go. Oh, Samir, you can go.
no, please be my guest, Ciara.
Peristernal long view looks like the left ventricle is quite enlarged, dilated, and looking at the mitral valve, it's opening, but the anterior leaflet doesn't look like it's moving that well.
It's perfect. I've got another view for you here.
And then a close-up of the mitral valve with color. Looks like, again, the anterior leaflet's not moving that well, and there's some MR that's posteriorly directed.
Excellent.
And then 4-chamber view, again, color on the mitral valve. There's, again, we can see MR, mostly posteriorly directed, but then I guess, is that increased flow as well? No, I would say just mostly the MR is what I see, as well as the left ventricular dilatation in this view with decreased systolic function.
Okay, great. Thanks, Carol. And so then, yeah, here's just a close-up. I just wanted to include this because they're did this to capture for PISA. And you can see kind of the area of proximal flow conversions nicely in these clips. Okay, perfect. So that was a nice example of secondary mitral regurgitation, which occurs when one or both leaflets are pulled apically into the LV, which is most often due to LV remodeling, causing outward displacement of the pap muscles. This can lead to incomplete leaflet closure, potentially restricted mobility, and leaflet tethering. Leaflet tethering can be asymmetric, in which case then you can see multiple or eccentric jets. So now we'll shift gears and talk a little bit about evaluating the severity of mitral regurgitation. There's a lot of different tools in your toolbox or in your echo toolbox for how to do this. So we'll talk about methods that you can use, from using color Doppler, such as the regurgitant jet area, assessing the vena contracta size, a qualitative assessment of proximal flow convergence, then using pulse wave Doppler, assessing the mitral inflow velocity, the pulmonary vein flow pattern, using continuous wave Doppler, how you can look at the regurgitant jet density and contour, how you also use CW to assess tricuspid regurgitation as a supportive sign, and then at the end we'll talk about quantitative Doppler using PISA and the stroke volume method. Okay, so to start off, for color flow Doppler and the regurgitant jet area, which is probably the kind of simplest one to conceptualize because it gives you a visual assessment of the largest jet in the apical view. I mean, this is not an apical view in the picture here, but essentially be a visual assessment. And so this can be reported as a jet area if you trace it, or if you could also give it as a ratio of the jet area to the left atrial size, with greater than 50% being considered suggestive of severe mitral regurgitation. If there's an eccentric wall impinging jet, which we did see in some of the previous images, that would also be considered to suggest severe mitral regurgitation. Advantages of using the regurgitant jet area are that it's easy to use, it's good for the exclusion of mitral regurgitation. However, there are some disadvantages in that the severity grading is not reliable, as well as the direction and shape of the regurgitant jet is going to impact your assessment. So a central jet may be overestimated, and an eccentric jet may be considered to be more severe than an a central jet may be considered to be more severe than a eccentric jet that is actually truly more severe. Another limitation is that if the mitral regurgitation is not below systolic, then this can overestimate. And next, we'll talk about using the vena contracta, which provides a measurement or tries to give a measure of the effective regurgitant orifice. So you obtain this in the parasternal long axis, and you assess the narrowest portion of the jet that emerges from the orifice, which you can see on the image here. A vena contracta width that's less than 0.3 centimeters would indicate mild mitral regurgitation. If it's 0.7 centimeters or higher, then that's specific for severe mitral regurgitation. Advantages of using the vena contracta are that it can be a surrogate for the effective regurgitant orifice, and it doesn't depend on flow or driving conditions like some other methods to assess mitral regurgitation severity do. However, disadvantages are that patients who have multiple or elliptical jets, you might underestimate what the severity is. And then lastly, on this slide, we'll just talk about proximal flow convergence and how you can also, in addition to PISA, use this to provide a qualitative assessment of mitral regurgitation. And so using, typically in the apical window, you would look to find the area of the hemispheric flow convergence. And if there's an absence of proximal flow convergence, that would usually indicate mild mitral regurgitation. In severe mitral regurgitation, you should see the flow convergence throughout systole. Some pitfalls of this are that, again, multiple or eccentric jets, it's less useful in multiple or eccentric jets, or if the jet is constrained. And in patients with functional mitral regurgitation, if there's a non-hemispheric shape, it might be less useful as well too. So moving on, we'll talk about how you can, which pulse wave Doppler methods you can use to assess the severity of MR. So to start off with the mitral inflow velocity, so this is based on the principle that severe MR would have dominant early filling with an increased E velocity due to decreased diastolic flow across the mitral valve. So you can see here on the right, and this is from in one of the cases that we saw earlier, I forgot which one, but you can see that the max E velocity is 1.5, so that's greater than 1.2. 1.2 or higher is supportive of severe mitral regurgitation. Advantages of using mitral inflow velocity is that it's easy to access. You should have on all patients who are getting an echo to assess MR. And if there is a dominant A wave, that should essentially exclude severe mitral regurgitation. Disadvantages are that high E velocity depends on LV relaxation and filling pressures. So it's not necessarily reliable in patients with secondary MR who have AFib or mitral stenosis. Then we'll talk about the pulmonary vein flow pattern. So in patients who have increasing mitral regurgitation severity, they can have blunted systolic velocity in the pulmonary vein. So you can see down here in the bottom right corner, we've got the normal profile with the dominant S up here in terms of pulmonary flow. And then with moderate MR, we've got blunting of the S. Here it's not dominant, the dominant's D, the diastolic. And then on the far right, we have systolic reversal, where you've got reversal flow during systole. So if you have a normal pattern on your pulmonary venous flow, then that would suggest non-severe mitral regurgitation. If you have flow reversal in at least one pulmonary vein, that is specific for severe MR. And then in between, if you have blunting, that could suggest mitral regurgitation. Advantages are, again, are easy to capture. You should have it on everyone, and that the dominant and that the systolic flow reversal is specific. However, some disadvantages are that while the systolic flow reversal is specific, systolic blunting is not, and you can have systolic blunting from other things such as elevated left atrial pressure of any etiology or atrial fibrillation. So next, we'll just briefly talk about how we can use continuous wave Doppler to assess severity of MR. So using the density and contour of the regurgitant jet, which we can see on the top, or we can see on the right here, this gives you a visual qualitative assessment of severity. And increased density would suggest more significant mitral regurg. Advantages are that it's easy to obtain, but some disadvantages are that central jets appear more dense than eccentric jets, which would be of higher severity, and also density is gain dependent, so there could be some error in interpretation there. Also, it's a qualitative assessment as well too. It doesn't give us a quantitative assessment. Another thing too over here that you can see on the bottom is that kind of the triangular contour with an early MR peak velocity would suggest a large regurgitant pressure, but an early peak velocity is not sensitive for severe MR. Tricuspid regurgitation, also use that to assess for consequences of MR, so to estimate PA systolic pressure, which is another supportive finding as an indirect marker of MR severity. Okay, so we'll talk about quantitative Doppler next, starting with PISA, which provides a measure of the effective regurgitant orifice area, as well as regurgitant volume and regurgitant fraction using the PISA radius, the aliasing velocity, and the peak MR jet velocity and the velocity time interval of the MR jet. So this is done in the apical window. So the sonographer or whoever's performing the study will lower the Doppler baseline and the Nyquist limit to find the hemispheric shape. And then afterwards, you measure the PISA radius from the point of color aliasing to the vena contracta, as well as measure the CW jet peak velocity. Advantages of using PISA are that it's a fairly rapid quantitative measure, which can predict outcomes in patients with degenerative and functional mitral regurgitation. But disadvantages are that small measurement errors can cause significant error in your outputs because the error is squared based on the formulas used. So this would be a particular concern in patients with either larger, so 1 centimeter or higher, or smaller radius, 0.4 centimeters or less. And then finally, PISA method might not be accurate in patients who have multiple or eccentric jets. And then these numbers down here just kind of divide into mild and severe criteria, but we'll touch on those in a future slide as well too. And then the last method for assessing MR severity would be the stroke volume method, which is another way of using quantitative Doppler, and it's based on the principle that the difference in inflow stroke volume and outflow stroke volume within a ventricle should be what the regurgitant volume is if there's only one regurgitant lesion. So using pulse wave Doppler to sample the stroke volume at multiple sites. In the case of mitral regurgitation, you would do that at the LVOT and the mitral annulus. And then the regurgitant volume should be the stroke volume at the regurgitant valve, so the mitral valve minus the stroke volume at the confident valve, so the aortic valve. And then using that, you can calculate the regurgitant fraction, and then using the, you can also calculate the ROA using the velocity time interval and regurgitant volume. Advantages of using the stroke volume method are that it's a quantitative measure, which is valid for multiple and eccentric jets. Like with the PISA method, you can get measurements for the regurgitant volume, RF, and ROA, which is, of course, having numbers and quantitative measurements is always very helpful. But disadvantages are similar to PISA, that multiple measurements can lead to increased risk of error, and measurement errors can be compounded. It's also not valid to use this method if patients have concomitant or aortic regurgitation, unless you're using pulmonic site for sampling. And then lastly, it can be a bit cumbersome with all of the measurements. So similar to mitral stenosis, of course, you want to look for the associated lesions. So in addition, looking for the left ventricular volume, looking for dilatation of the LV, and then left atrial dilatation, and assessing the PA pressure with TR. So this table here is from the ASC guidelines on mitral regurgitation, which breaks down the different methods that we had talked about into mild, moderate, and severe MR. And so this table here I think is really nicely lays everything out and be really helpful in terms of kind of organizing an approach. So, and for mild MR, the mitral valve morphology would either be normal or just very mild leaflet abnormalities. Looking at the color flow jet area, it would be small, central, and not taking up the whole systole. Same with the flow convergent, would either be small or not visible. Vena contracta less than 0.3. The pulmonary vein flow should show systolic dominance. In mitral inflow, if there is, this is not a necessary criteria for mild, but if there is A-wave dominant, that would be more suggestive of mild. And then from quantitative measures, so an effective regurgitant orifice area of less than 0.2 would be mild, regurgitant volume of less than 30, and a regurgitant fraction of less than 30% would be considered mild. And then on the flip side, in terms of severe, for the mitral valve morphology, you would see severe changes on the mitral valve leaflets, so either flail leaflet, ruptured palp muscle, or otherwise. On color Doppler, you should see a large jet that with flow convergent would be large throughout systole. The vena contracta would be 0.7 or higher. In the pulmonary vein flow, you'd have either systolic blunting or systolic flow reversal. And then for mitral inflow, you would expect to see E-wave dominance with a max E velocity of 1.2 or higher. The EROA would be 0.4 or higher, and the regurgitant volume would be 60 milliliters, and regurgitant fraction of 50% or more. So this again is from the ASC guidelines, and is their schematic for assessing chronic MR. So essentially, you consider all of the things that are on the previous table for mild and severe MR, and if there's 4 or more for criteria that are definitely mild, then you would consider this to be mild MR. If there's 4 or more for severe, then you would consider it to be severe, and if it's in between, then ideally you're able to perform some quantitative methods to help further guide if it's moderate versus mild versus moderate to severe. And then I also included here, again, from the 2020 guidelines, the staging for chronic primary MR, which overall is fairly similar to the echo guidelines, and then staging for chronic secondary MR. Okay, so very briefly in the next 5 minutes, just going to go over a few more slides. So this last case here is a 52-year-old man who's admitted to hospital with fever and staph bacteremia with new dyspnea and increasing oxygen requirements. Anyone want to take a stab at this?
It's Mike. I can go.
Thanks,
So
Mike.
apical 4-chamber view, biventricular systolic function looks normal. Pay attention to the mitral valve. That anterior mitral valve leaflet on the atrial side, there appears to be there's something there, like an independently mobile. In the context of his bacteremia, could be a vegetation. The leaflet tips themselves appear to be coapting okay, but I'm wondering if there's like a little bit of a gap that you see in that anterior leaflet near that, what I think is a vegetation. So, I mean, there could be a perf, and color will be helpful.
So here's some color for you.
Totally, yeah. So, I mean, in that around that area where we saw, there's a jet of mitral regurgitation through that. That's not through the actual coaptation of the leaflet. So I'd be suspicious of perforation here.
Exactly. Yeah, that's exactly what this is. Okay, so because we don't have much time left, so I'm just going to very briefly mention. So acute mitral regurgitation, again, there's a number of etiologies that can cause this. So before the reperfusion area, this would have been most commonly caused by pap muscle rupture post-MI. Thankfully, we're not seeing that very often anymore. But other causes that you can see are endocarditis, such as in the last images there, causing leaflet perforation. In myxomatous valve disease, you can have portal rupture. And then you could also have device-related or in patients with a stress-induced cardiomyopathy. In terms of echo findings, an important thing to consider is how acute MR is different than chronic MR on echo and overall clinically. So because it's happening so quickly, you're not going to see the changes in the left atrial or left ventricular size. It might also be underestimated on echo. So if you see in this diagram here in chronic MR and as opposed to acute, the changes can look quite different. Sometimes you can see a flail leaflet depending on the etiology. You can see other things such as vegetations or ruptured pap muscle head, either dissected or ruptured chordae. If the transthoracic is equivocal and the patient's stable enough, then a TE can often give you more information in terms of the severity and etiology. Okay, and that's all that I have for everyone. So thank you so much for listening. A few minutes for our questions.
So just want to say thank you, Ciara, for such a great comprehensive review. This is the kind of questions that all the cardiology residents and the echo fellows have to know for their respective exam in Royal College in Cardiology, as well as for the echo exam. Although the extent and details will varies a little bit, but that this is the bread and butter of what we do. Also, thank you to the participant, especially the cardiology residents who chime in to help interpret the echoes, and you've all done a fantastic job. So just one quick historical caveat. Mitral valve is supposed to be named by Leonardo da Vinci, who named the valve as Bishop Mitral, which is the Italian way of saying the bishop head. So that's one of the interesting historical facts. Another thing is that a good approach to remember on MR and MS or any valvular heart disease for that matter, in terms of echo interpretation, is looking at, describing all the 2D features and then the Doppler findings, and then the quantification. And then that will provide you a good way to actually organize our thoughts about how to memorize all the different things to look for and when you're interpreting it. Okay, so with that in mind, any questions from the audience or comments?